So today we're looking at endocrinology for step 2 CK from the book Master the Boards. And this is going to be the first section that we are going through. So I'm going to read this book and I expect you guys to just follow along. Okay. So first we have pituitary disorders, uh, pituitary incidentaloma. So by definition, an incidentaloma occurs, okay, there's a bit of a misprinting over here. So what basically pituitary incidentaloma is that it is basically a pituitary lesion discovered incidentally on imaging in an asymptomatic patient. So if a patient is undergoing imaging for any other reason and tumor is discovered in the brain or in the pituitary, now the patient is asymptomatic. So we would not do any confirmatory tests because the patient is asymptomatic, then we have nothing to test him about. So what basically this is when a patient, for example, is undergoing brain imaging for stroke, for example, he's undergoing CT scan or MRI for a neurological disorder, and we could visualize a tumor in the pituitary gland. But as the patient is asymptomatic, that's why we would not do any uh, confirmatory tests. So this would be known as pituitary incidentaloma. So incidentaloma being the reason that the tumor was discovered incidentally. Now, how do we manage this patient? The management depends upon the tumor size. So, if the tumor size is less than 1 centimeter. What we do is we give him prolactin treatment and we do yearly MRI. Why do we give prolactin treatment? Because it's mostly the most common one is prolactinoma. So, we give him prolactin treatment just so that there is not a deficiency of prolactin because the most common being a uh, prolactinoma. So we check prolactin levels and we do yearly MRI. And if the tumor size is more than 1 centimeters, then we would do 24-hour urine cortisol. We will check the thyroid levels. Basically, we'll check all of the hormones that are present in the anterior pituitary. We would also check for the any defects in the visual fields so that we could rule out any optic chiasm compression. And we would also carry out MRIs yearly and prolactin levels. So what we are doing is we're just keeping an eye on the patient. If the tumor was less than 1 centimeter, it is less likely to cause a compression, and if it is more than 1 centimeter, then it is more likely to cause a compression. So that is why if it is more than 1 centimeter, we do we check for visual field defects if there is any compression. Also, because larger tumor means that it is more dangerous, so we also check the level of all of the anterior pituitary hormones. So that being cortisol, ACTH, and thyroid hormones and LHFSH, along with checking the prolactin levels. Okay, so empty cellular syndrome. This is basically a disorder in which the pituitary is undersized, flattened, and not visible on MRI. So you can see the empty sella turcica on your MRI. You cannot visualize the pituitary gland. Now, this can be an incidental finding, and it can be associated with surgery, obesity. So, just like to highlight this that surgery, obesity, and radiation therapy are important because I have seen you were asking these questions, so these are important. Obesity specifically, I've seen being asked quite a lot. So the patient was obese, and there was MRI done for some reason, and the Celadurcica was empty. Radiation therapy is another important one. So they do tend to ask questions on this topic. So you need to keep in mind all three of them are important causes and potential clinical questions. However, 70% are idiopathic. When asked how to manage asymptomatic ASS, check, answer, check thyroid and adrenal function. So, of course, if the patient is asymptomatic, you can't really do anything, and you shouldn't do anything. You don't want to overtreat the patient. However, to rule out any problem, any other problem, or any problem that is at this point subclinical when the patient is presenting and has the potential to turn into a clinical problem, we need to rule out any thyroid or adrenal pathology. So we need to check that they are working properly or not. Because if they get affected, then it might prove to be fatal for the patient. So I will show you the empty Salah syndrome. So as you can see, this is the empty Sella turcica. You can see it's completely black. There should be normal pituitary gland present in this space. So let me show you another image. As you can see, you can clearly see that this is empty, this part where the arrow is pointing. Whereas in this image, you can see that it is filled. You can see there is with the presence of pituitary gland in this part, in the Sella turcica. But in this image, it is not. You can see the difference between both of them. Okay. So you need to, if the patient is asymptomatic and they're asking you what to do, what is the next best step, you just need to check thyroid and adrenal function. This is your answer. Panhypopituitarism. Panhypopituitarism is caused by any condition that compresses or damages the pituitary gland. Of course, evident by its name, it means that everything is low that it originates from pituitary gland. So, what could be the cause? Tumor, which is an obvious cause. It could be a metastatic cancer, it could be an adenoma, it could be a Rathke cleft cyst, and it could be a meningioma. So these can cause panhypopituitarism. Trauma and radiation, of course, can cause it. Hemochromatosis is another important cause. Sarcoidosis is another important cause, and histiocytosis X is another important cause. Although this is rare, very rare that they ask this, but these two have been asked. Hemochromatosis and sarcoidosis. They basically do infiltrate the pituitary gland. They infiltrate the pituitary gland and then they cause problems. Infection with fungi, TB, and parasites, TB being the one that you must remember. Autoimmune or lymphocytic infiltration can also occur. So there are multifarious reasons for this, but most commonly we see it in tumor, we see it in trauma, we can see it with hemochromatosis and sarcoidosis. TB is also very common, and autoimmune is a bit common, not that much. It's a bit rare, but you have to keep in mind all of these causes. Okay, anything that damages the brain, from tumor to stroke to infection to trauma, can cause hyperpituitarism. So it's an easy way to remember that anything that can damage the brain can uh, cause it. Symptoms are based on the deficiencies of the specific hormone that is deficient. So if the patient is deficient in prolactin, uh, he would give a certain set of symptoms. So in men, there are never any symptom of prolactin deficiency. In women, however, prolactin deficiency inhibits the lactation after childbirth, and if it is deficient, the patient cannot lactate normally. However, males do not develop any such kind of symptoms for obvious reasons. A deficiency of growth hormone can be assessed when the child presents with short stature and dwarfism. Adults have few symptoms because several other hormones, uh, catecholamines, glucagon, cortisol, act as a stress hormones. Certain findings include central obesity elevated LDL, cholesterol, and reduced lean muscle mass. So this can be caused by a deficiency of growth hormone, central obesity, elevated LDL, reduced lean muscle mass. And it's quite easy to keep in mind because if you remember the physiological effects of growth hormone, then it would be easy to know what happens in its deficiency. Deficiency of luteinizing hormone and follicle stimulating hormone. Men will not make testosterone or sperm because FSH has a role in the maturation of sperm. They will have erectile dysfunction. So this is for you to keep in mind. It's a clinical manifestation. And decreased muscle mass because of decreased testosterone, of course. So they would have decreased libido and they would have decreased muscle mass. Women will not be able to ovulate or menstruate normally and will become amenorrheic. So this is the part for women to keep in mind, and both will have decreased libido. This is going to happen in both, and decreased axillary, pubic, and body hair. So you need to keep an eye out on these symptoms. These would happen in both of them. Decreased axillary, pubic hair, and body hair. However, erectile dysfunction and decreased muscle mass will be only seen in men. Okay, so they are comparing two symptoms here. Kallmann syndrome, which is related to the COL1 mutation, and the Klinefelter, which is not related to any mutation. It's just a trisomy. So it depends on XXY karyotype. Relation to FSH and LH. So in Kallmann syndrome, both of them are decreased because there is decreased GnRH. In Klinefelter syndrome, there is androgen deficiency through insensitivity to FSH and LH despite high. So in Klinefelter syndrome, there of course the androgens will not get produced, and this would lead to high FSH and LH levels in the blood because there is a lack of feedback inhibition. That is why. Kallmann syndrome is classically associated with anosmia, renal, and agenesis, which is also important. People tend to remember the anosmia part, but the renal agenesis is also important because it is in half of the patients. Klinefelter syndrome, people are tall most of the time. So this is a basic difference that you must keep in mind, both of them. That Kallmann syndrome has decreased FSH and LH, and Klinefelter syndrome has increased FSH and LH. The reason is that Kallmann syndrome has a genetic defect, and Klinefelter has basically a feedback inhibition defect. The treatment for both of them is to replace testosterone. So whatever hormone they are missing, just give them the hormone, and you're good to go. Symptoms of hypothyroidism and hypotension will be covered in the section devoted to these glands. Okay. Hyponatremia is common secondary to hypothyroidism and isolated glucocorticoid overproduction. So hyponatremia can occur due to hypothyroidism and isolated glucocorticoid underproduction. Okay, that makes sense. Potassium level remains normal because aldosterone is not affected. A is not affected. Of course, aldosterone is not in the pituitary, so it's not affected. Aldosterone then excretes the potassium, keeping potassium levels normal. However, because thyroid and glucocorticoid, ACTH, is related to the pituitary, so both of them are going to be affected, which is going to lead to hyponatremia. Okay. MRI detects compressing mass lesions in the pituitary, so MRI is your imaging of choice. Do initial tests. What is the diagnostic testing? So we have to do initial tests for suspected panhypopituitarism. We have to check all of the hormones. And for suspected growth hormone deficiency, the best stimulatory test is injecting growth hormone releasing hormone. The normal response to GHRH is rise in GH level. Okay, so this is specifically this test is for the growth hormone deficiency to check for it. So if you inject the releasing hormone, it would lead to a rise in the subsequent hormone, the growth hormone, which is which makes sense. Physiologically, it does make sense. Uh, but if this response does not occur, that means that there is a deficiency of growth hormone. So now uh, they have signified some important blood tests for the specific hormone. So first of all, testing thyroxine levels and TSH. Uh, there would be low TSH and low thyroxine levels, and decreased TSH response to thyroxine releasing hormone. So we will give the patient thyroxine releasing hormone, and TSH should increase, but it will not it will either not respond to us injecting TRH, or either it would show a very less response. So this is something that you can confirm with for thyroids. And then there is decreased ACTH and cortisol levels. Normal response to co-syntropin stimulation of the okay of the adrenal cortisol will rise. So if we put in co-syntropin, cortisol will rise in recent disease, but abnormal in chronic disease because the adrenal atrophy. So if there is adrenal atrophy, then co-syntropin will not work. It will not work, and there will be no rise in the ACTH levels with the corticosteroid releasing hormone. And elevated baseline cortisol level excludes pituitary insufficiency. So if there is uh, there's not a decreased cortisol level but an increased cortisol level, then it would show us that there is no pituitary insufficiency present. Then there is some other problem that is present. Okay, and decreased ACTH is quite self-explanatory. Decreased LH and FSH levels and decreased testosterone level. These would confirm the LH, FSH levels and the testosterone levels respectfully. So we don't need to confirm it because these themselves are sufficient enough. Okay, if we want to check for growth hormone levels, then we can directly check for growth hormone levels. If they are low, then we can confirm them by giving them the GH releasing hormone. And if there is no response, then we confirm that growth hormone is deficient. Also, there would be no response to the arginine infusion, which normally does produce a pulsatile response in the growth hormone. And finally, if we test for prolactin, then the level will be low, but it is not helpful because prolactin doesn't have its treatment. It doesn't have really a complex treatment. So it is confirmed with no response to TRH. So if you give TRH, prolactin levels should increase, but it will have no response. Some other tests that are useful, such as a metarapone test, and what happened is basically we metarapone inhibits 11 beta hydroxylase, and this decreases the output of the adrenal glands. So what basically should happen is that metarapone should normally cause increased ACTH levels because it is uh, inhibiting cortisol production. So cortisol levels go down and ACTH levels should rise. But that's not how it happens because cortisol is a feedback. Uh, because cortisol has a feedback inhibition, so that's why the cortisol has to go down. If there is deficiency of ACTH levels, then they will not rise. I've written it over here also as well. So pitarapine blocks beta hydroxylase. There's going to be decreased cortisol synthesis, and normal pituitary responds with increased ACTH. This is a normal response. But what happens is that there is no ACTH rise because ACTH is going to be low. Okay, and there's another test which is old but useful. It is the insulin stimulation test. This has the normal effect of insulin inducing hypoglycemia, is a rise in GH levels. So insulin induction is a rise in GH levels, and GH increases glucose levels because it is a stress hormone. So it is a diabetogenic hormone. Insulin-induced hypoglycemia as a test is always a wrong answer. So you need to either choose insulin stimulation or any other option, not insulin-induced hypoglycemia. Do not answer dexamethasone for deficiency of adrenal steroid hormones. It has no mineralocorticoid activity, right? So it's not the dexamethasone is only deficient. We need to look at the complete picture. We don't have to directly just answer dexamethasone because it is a stimulation of ACTH. ACTH is deficient, so we will not just answer dexamethasone. And finally, the treatment is that we are going to replace deficient hormones with their respective hormones such as cortisol, thyroxine, testosterone, estrogen, and recombinant human growth hormone. Okay, again, this is clear now. Pituitary, posterior pituitary. The two products of the posterior are ADH and oxytocin. There is no deficiency disease described by oxytocin, but oxytocin helps us understand that it provides uterine contraction during delivery. But delivery still occurs even if it is absent, so it's not the most important part, but still very important. ADH deficiency is also known as central diabetes insipidus, so we have to keep that in mind. Acromegaly is the overproduction of growth hormone, leading to overgrowth of soft tissue throughout the body. So the causes include 95% of cases pituitary adenoma. It's the most common cause. Men syndrome when combined with parathyroid pancreatic disorders such as gastronoma or insulinoma. Then men syndrome can also cause it. And atopic growth hormone and growth hormone releasing production from a lymphoma or bronchial carcinoid. So this is the most rarest form, but this is still a cause. So you have to remember these causes are quite important. What is the most likely diagnosis? If they ask you this question, you need to look out for these signs. So because acromegaly enlarges soft tissues like cartilage and bone, it can result in increased head size, ring, and shoe size. To remember all three. Carpal tunnel syndrome classically can occur, and obstructive sleep apnea can also occur from enlarging soft tissues. Body odor can occur due to sweat gland hypertrophy, and they're going to be coarse facial features and widening of the jaw growth. There's going to be a deep voice, macroglacia, which is a fancy term for big tongue, chronic polyps, skin tags, prawn tensor, arthralgias from old arthralgias from joints growing out of alignment can cause arthralgia, and hypertension resistant to treatment. It's very important. Resistant hypertension. Uh, it can be due to acromegaly, and cardiomegaly is very important because most patients die of heart problems and erectile dysfunction from increased prolactin concentrated within the pituitary adenoma and hyperglycemia. Abuse of growth hormone can give the same presentation as acromegaly. Fine, lab tests will show glucose intolerance, hyperlipidemia, which contribute to the cardiac dysfunction. Okay, okay, so lab test will show you the glucose intolerance, hyperlipidemia. So this could be a point to remember. Insulin-like growth may Insulin-like growth factor level is the basically best initial test, and the most uh, accurate test is the glucose suppression test. That's the most accurate test. So you need to remember this difference. So best initial test is IGF-1 level, and the most accurate test is the glucose suppression test. Okay, this is the main bulk of the step 2 CK, the best initial and most accurate tests. Normally, glucose should suppress GH, but if it doesn't, then you know that there is something wrong because it's getting produced so much more than the glucose is not able to suppress it. MRI should only be done after lab identification of acromegaly. Prolactin levels are tested because of co-secretion with GH. That is the rationale for testing prolactin levels. The treatment would be as follows: transsphenoidal resection of the pituitary, 70% success rate. This is what is done majorly, and large adenomas are harder to cure. So first this is the first part. We go for surgery, and the second step is we go for medications. If something is not done in this step, we go for medications. The medications being cabergoline, dopamine inhibits growth hormone release, octreotide or lanreotide, somatostatin inhibits growth hormone release, and pegosamant. It is basically a growth receptor antagonist, which inhibits IGF relief from the liver. So you have to remember all of these three, very important. Cabergoline is the first medication that is assigned, but medications themselves are a second part of your treatment. First is the resection. And radiation is only done when there is no response to surgery or medication. So if GH is an anti-insulin, why does it make an insulin-like growth hormone factor? Only the effect on protein and amino acids is insulin-like. This might confuse some students that if GH is a diabetogenic hormone, why does it make insulin-like growth factor? Because it's only named due to its effect on the proteins and amino acids. Its effect is anabolic, just like insulin is anabolic. So diabetes insipidus is discussed in the nephrology chapter. Hyperprolactinemia. Hyperprolactin can seem confusing because so many causes have nothing to do with the pituitary adenoma. Causes of elevated prolactin include physiological causes, pregnancy, intense exercise, renal insufficiency, and increased chest wall stimulation. So these are physiological causes. Hypothyroidism can cause elevated prolactin because high TRH will stimulate prolactin secretion. So let me highlight this because this is important. It's quite important that high TRH levels will stimulate prolactin secretion. Acromegaly can cause it because prolactin can be co-secreted with GH. Cutting the pituitary stalk eliminates dopamine delivery to the anterior pituitary, and dopamine inhibits the prolactin release. So there are three relations over here. One is the high TRH is equal to high prolactin secretion, and high growth hormone secretion is equal to high prolactin secretion, and then high dopamine secretion is equal to low prolactin secretion. So there are three relations that you need to remember, right? These three bullet points show that. Certain drugs, very important, very important. Certain drugs, antipsychotics, methyl dopa, metoclopramide, opioids, tricyclic antidepressants, Rapamil. These are all of these are important, very important. You need to remember all of them. Rapamil is the only calcium blocker to raise prolactin levels. So this is apparently an important point. They have written it in the colored box. Symptoms include for women galactorrhea, amenorrhea, infertility. For men, it is erectile dysfunction, decreased libido, While men may experience gynecomastia, women very rarely experience galactorrhea. So this is a point that you must remember that if galactorrhea is not mentioned in a patient, it doesn't mean that prolactinoma is not there or hyperprolactinemia is not there. After the prolactin level is found to be high, diagnostic tests include thyroid function test, pregnancy test. To rule out other causes, you need the BO and creatinine because kidney disease elevates prolactin. We've already looked at over here. Renal insufficiency. So you need to check BO and creatinine and LFTs because cirrhosis also elevates prolactin. So keep in mind these 2 points. Kidney disease and liver disease can elevate prolactin as well. So always exclude pregnancy first in any woman with high prolactin levels. This is the first step in evaluation. So if they ask you what is the first step in evaluation, this is the first step to always exclude pregnancy in a woman with a high prolactin level. MRI is done after prolactin level is confirmed to be high. After it is confirmed to be high, secondary causes like medications are excluded and the patient is confirmed not to be pregnant. So only after doing these three things you will do MRI. First, you need to confirm that the prolactin level is high, and second, you have to confirm that all the medications are excluded. These medications, antipsychotics, methyl-dopa, metoclopramide, opioids, TCAs, verapamil, you have to exclude them, and then you have to confirm that the patient is not pregnant. Only then you will move to MRI. You will not move to MRI unless all of these conditions are satisfied. So they can, in the question, give the question. They can design a question on any one point, on any one of these points. With any endocrine disorder, MRI of the head should never be done first. That's what we discussed. It is a sort of an expensive and time-taking procedure, so you have to go for the baseline evaluation first. And the treatment should be as follows. So this is the first step in treatment. Always go for cabergoline. Then you go for bromocriptine. So these are dopamine agonists. Bromocriptine can cause orthostasis, lightheadedness, nausea, and vomiting. So cabergoline is always preferred more than bromocriptine. So remember this. Transfemoral surgery, if no response. So this is the second step over here in acromegaly. This was the first step, but in hyperprolactinemia, this is the second. And radiation can be a rare option. And asymptomatic hyperprolactinemia does not need treatment. So if it is asymptomatic, then don't treat it. Yeah, keep this in mind. Okay. Gynecomastia. This is an increase in the size of breast tissue arising from either it can arise due to Klinefelter syndrome, most commonly, hyperprolactinemia, second most commonly, or drugs in which spironolactone is asked quite a few times. Ketoconazole and estrogen are also asked. Never heard them ask opiates, but it is mentioned here, so you might as well remember them. Liver and renal failure. This is also a cause of elevated prolactin levels, which I'm telling you guys to remember again and again. And testicular lesions can also cause gynecomastia because Sertoli cells make estrogen. So if they overproduce estrogen, this can lead to gynecomastia. Testing should be done to exclude these disorders. Do mammography to exclude cancer because gynecomastia can present with an increased risk of breast cancer. And do remember these drugs as well, guys. It's quite important. The treatment would be as follows. You would give first line would be tamoxifen, and then you would give testosterone replacement if there is testosterone deficiency. So if they don't mention testosterone deficiency, you can go for tamoxifen. But if they do mention it, then you have to replace testosterone and carry out surgery if there is a refractory case. And we are done for the pituitary disorders.